Good. Okay. Thank you all for joining us. While I'm talking, if somebody could once again simply type in the box that you can hear me, and we'll sort of monitor the box and make sure that our audio is live. We're going to start in about 1 minute. Okay, good deal. Everybody can hear us. Very good. So, yeah, these webinars are always a challenge. You never know if everything's working correctly or not. So, thank you very much for joining us. My name is Patrick Steffen, the Chief of Managed Care for the Ohio Department of Medicaid. We have a number of folks in the room here with us, and if you don't mind, I'm going to allow everyone to introduce themselves, just so you all know that quite a few folks have on this initiative, including many staff here at the Ohio Department of Medicaid, the Ohio Department of Job and Family Services, as well as our managed care plan. So one moment while we go around the room and introduce ourselves.
Hi, Amy Baldridge, Paramount Advantage.
Albany McIntyre, Medicaid Managed Care.
Nicole Northrop, Medicaid Managed Care.
Sean Bracely, Medicaid Managed Care.
Laurel Smith, Medicaid Managed Care.
Alicia Allen, SACWIS.
Christine Day, Molina Healthcare of Ohio.
Jessica King of Buckeye Health Plan.
Christine Haydock of Buckeye Health Plan.
Tricia DeLong from CareSource.
Donna Gabbard, CareSource.
Natalie Minzor from CareSource.
Roxanne Richardson, Medicaid Managed Care.
Kelly Higginbotham, Medicaid Managed Care.
Very good. So as you know, this is a webinar to talk through the children in custody enrolling into managed care. And we use that term, of course, as you know, to identify the foster children, as well as the adopted children throughout the state of Ohio. There are about 14,000 individuals that will be enrolling into managed care. Frankly, from now until after the beginning of the first of the year in 2017. We started this initiative with a work group about a year ago and sort of worked through a number of implications and are making every effort through this initiative to ensure that the kids enroll into managed care with the least amount of disruption as possible. We have looked at this as a way to improve the health outcomes of the children that we serve, as well as to provide some additional benefits through our managed care plans, which the children do not currently receive through Medicaid fee-for-service. So, just some housekeeping efforts before we start the slideshow. There is a question box that you should be able to see on your computer screen. If you have a question as we're going along, feel free to type those in, and we will try to address them at the end of the presentation. If we don't have time to address them all, we will be distributing and posting answers to your questions, I believe, on our website. We also have developed a frequently asked questions document some back or so, and we will make that available to those of you that have not seen it to date. This is actually the last in a series of trainings that we've done. We spent earlier, late summer, we did a number of regional trainings that were actually very well attended by PCSAs, county staff, parents, as well as providers. So this is kind of our last foray into the official Medicaid JFS trainings. I do want to point out for all of the folks that work for counties or PCSA that coming soon there is going to be a webinar / demonstration on some of the changes that we are putting into place in SACWIS as a part of this initiative. So look for some of that information to come out in the very near future, because as part of this, if you haven't heard, all children in custody will have their eligibility determined in SACWIS, and it will no longer be a sort of half and half, some folks in Ohio benefits and some folks in SACWIT. So that should be a huge plus for a number of folks that work for PCSAs and counties. All right, with that, we're going to go ahead and roll into the slideshow. You know, if you don't know, just a couple of quick thoughts on Medicaid in Ohio. I mean, we are the single largest health insurance company in the state. There are over just about 3 million people in managed care, or in Medicaid today, excuse me, and 86% of them, or 2.4 million of those folks, are already in managed care. We do have the benefit of having a number of really strong managed care plans throughout the state of Ohio. You know, you can look at that list right on your screen and see CareSource, which happens to be our largest managed care plan in Ohio, a homegrown company that has done really good things in Ohio for a number of years. Molina Healthcare, which is actually a national plan. Buckeye Health Plan is also a national plan known as Centene from the corporate level. Of course, I don't think United Healthcare needs any introduction. And Paramount Advantage, which you know, has been an excellent managed care plan affiliated with ProMedica up in northwestern Ohio and is now statewide. So, you know, I'll say it like this. Anytime we get criticism about, you know, moving from fee-for-service to managed care, you know, the answer is pretty simple. You know, we don't feel as a state that we can adequately cover Medicaid lives from a fee-for-service perspective with state employees nearly as well as our managed care plans can. They do have the benefit of national exposure. They have the benefit of having much larger organizations and professionals on their teams than Medicaid does at the state level. So we have pursued the direction of essentially enforcing strong contractual requirements with our managed care plans. And as you see today, it is a partnership. We have obviously strong authority over our managed care plans, but every step of the way through this initiative and through our other initiatives, they're at the table with us. They're working hard to achieve our goals through anything that we do. And you know, frankly, we're excited to extend this benefit to the children in custody. I think it's been a long time coming, and I look forward to a successful initiative. Oh, that right. All right. So the next slide on your screen is really, you know, when we were out doing our regional trainings, this is kind of like the commercial portion of the PowerPoint presentation. And really, I don't think that I need to read all of these benefits, but they're on your screen. One thing I will say is, from a Medicaid perspective, you know, we seek to ensure, probably our #1 goal through the Medicaid program is to ensure adequate access to services. And the one thing that the managed care plans have done time and time again better than what we are able to do in fee-for-service is to provide adequate access. When we have a service or a provider shortage in an area from a fee-for-service perspective, as a state, we don't have a lot of tools in our toolbox. Our managed care plans have the ability, and we regulate them to the effect that if they don't ensure adequate access, they get penalized and they get fined in many instances. They've got a lot more flexibility than we have in managed care, and if you didn't know this, you know it now. Managed care plans are not bound by all of the same requirements that we are in fee-for-service. They can even pay providers more than we can pay in Medicaid fee-for-service. You know, the implications there are pretty obvious. If they can't seek a provider because providers don't want to accept the Medicaid rate, they can exceed the Medicaid fee-for-service rate, which oftentimes has led to their increased ability to provide services through managed care than in fee-for-service. Of course, probably the second most important aspect of using managed care is providing care management. Through our fee-for-service program, we don't do this as a state. through our managed care program, we have a number of requirements ensuring that the plans are also providing care management, care coordination. You know, as part of this initiative, we are looking to our managed care plans to make certain that their teams and their care managers are working closely with our counties and our PCSAs on all the kids involved. You know, one thing that we've said sort of over and over is that the care managers working with the plans are not replacing staff at the local level. They're really looking to stand in the gaps and work as part of a team to make sure that the services the child needs, they're receiving them. And then the other sort of points up on your screen are really just some of the value-added benefits that managed care brings to the table. You know, in a lot of ways, plans offer additional services over and above what fee-for-service provides, and sometimes they do that to better recruit members, and sometimes they do that because it's the right thing to do. And again, I would go back to the point where they have much more flexibility as a managed care plan than we do in the fee-for-service program. Lastly, I would say, you'll see the bullet down there at the bottom about improving health outcomes. Every time we have an important initiative, and this is one of them, we are able to use our plans who have a presence all across the state and the ability to interact with families on a local level, as opposed to staff working in the Lazarus building in downtown Columbus. A much stronger ability to push forward our important initiatives, such as moving children in custody into managed care, such as our infant mortality initiative. They are sort of the most critical point in Ohio Medicaid to move some of these initiatives forward. So we're really looking forward to a good collaboration. I know the plans have been very energized with this initiative. In fact, in some cases, we will talk through in this PowerPoint. We've started a pilot project already, and some of the plans have already engaged a number of the counties on children already to enroll them into managed care a little bit early. So I think it's exciting. I think it's a good thing for our state. Last thing I will say before I hand it over to Nicole, there's going to be bumps. We recognize that this is change. We recognize that there are some unanswered questions. It's a change in process. It's a change in who you interact with. There are going to be some cases, there are going to be things that pop up that are going to drive you crazy, that you're not going to understand. You may not be able to reach a managed care plan. You may not be able to get the care manager right away. There will be some bumps in the road. We think that we have laid out the transition schedule to a point where it will be most successful. So we would ask for your patience and your collaboration. In order for this to be successful, we really do need the PCSAs and the counties to do everything they can do, along with our managed care plans, to close these communication gaps and to work to improve the services that the children are receiving. All right, that's you?
I guess so.
All right.
So this is Nicole. We're going to go over what some of the additional benefits are and the differences are between fee-for-service and managed care. One of the biggest differences with fee-for-service and managed care is if you're in fee-for-service, you're on your own. You have to find your own providers. You have to find people who take Medicaid. You have to basically try to do everything on your own, where that's part of what the managed care plan's responsibilities are. That's why they have a member services hotline. That's where the care managers can come in, and if your child got hurt playing a sport, and then so you go to your initial visit, and then you have to do follow-up physical therapy, the plan is there with you the entire way, helping you find those providers, get those scheduled appointments, and they actually even will provide transportation to those appointments to help you out. Another thing is we have, with fee-for-service, you get a paper monthly card. Each person will have their own permanent ID card that will still have their Medicaid ID or their Medicaid billing number or recipient ID, depending on who you're talking to, because everybody refers to them as a different thing. But it still has that number on it that you give it to your provider, and your provider knows to bill the managed care plan based on that. Another really big deal is with fee-for-service, there's really nobody for anybody to call. The managed care plans have their member services line, which I'd mentioned. That number's on their card. They have a 24-hour nurse advice line, which is also listed on the card. So, you have those instances when it's after hours and your child gets hurt or child gets sick, and you're just not sure, should you go to the ER or should you wait, or is there something you can do in the meantime? That 24-hour nurse advice line is a really great tool to help you kind of sort through things to see what the best course is for you to take with your child. And then again, the care managers, which will help fill in the gaps, help refer you to services that you need, help find you appointments that you need, help set up your transportation and everything that you need. And then the managed care plans are required to cover all of the current fee-for-service medically necessary benefits, but then each of the plans also offer some additional benefits. And Patrick had alluded earlier to the managed care plans have contracts with us, and there's sanctions and point systems and things like that. And so basically every managed care plan that works with the state of Ohio has to sign the Medicaid provider agreement. Every provider agreement says the exact same thing, so all the managed care plans are required to provide the exact same things. They're responsible for the same thing. And we actually here at Medicaid have a designated set of staff that is all that they do, is work with the managed care plans in their contracts to make sure that they're in compliance with their contracts. If something's not looking right, then they're working with the managed care plan to say, is there a corrective action plan that needs to happen? Is this where you start getting fined? And that is all that they do, is they monitor their managed care plan and complaints that may come in for them or provider concerns that may come in for them. It's a everyday process. And they also work with the consumer and the managed care plan when issues arise to see what all's going on. And if there's miscommunication, get it ironed out so that way the consumer can get the services that they need without any further issues. There are member complaint portals that if there are issues, the members can get online and file those complaints through the portals, and the contract administrators do monitor those every day. There's provider panel requirements that Patrick had mentioned before, that the plans are responsible for ensuring that in every area around the state, there's enough providers in their panels and in their networks to service the consumers that they have to care for. There's the grievances and appeals and state hearing process in case something doesn't get approved for some reason, or if you're just not satisfied with maybe the speed of the services a physician provided you. You can call up the plan and say, hey, you know what, okay, yeah, I got to see this doctor, but I waited for 2.5 hours in the lobby. That's stuff that they're going to want to know, because they want to be able to work with that physician and figure out what's going on so that you can get the best care as quickly as possible. Each plan has prior authorization requirements, and we'll go through the details of those a little bit further in the presentation. But also each plan is held to performance and quality improvements through surveys. There's annual reviews. We now have managed care provider report cards that are actually on the Ohio Department of Medicaid website. And then there's additional federal reporting and monitoring requirements that the plans have to do also. As Patrick said earlier, we've been working with stakeholders and work groups and the Children's Services agencies since last summer, so 2016, or since 2015, I apologize. And so were a lot of decisions that have been made along the way. One of the big ones is the transition of care requirements. So these children have been fee-for-service for years, and the managed care plans are going to take over their services and with the providers and everything. And so the managed care plans have very specific requirements of continuation of services that children are already receiving until they can assess the children, see if, do they need more services? Do they need less services? Could they be better served in a different way? And so they're required to continue all of those services so that the children don't just automatically lose their services. And once they enroll in the managed care, our systems will actually go back and look at the fee-for-service history and send that fee-for-service utilization history and prior authorization history to the plan so that they know what they're looking at and where to start talking with the consumers about the children. And children who reside out of state are not eligible for managed care enrollment, but those residing in state and receiving some services out of state will maintain their managed care enrollment. A lot of times you'll see that with like the border counties, that a child has a better provider that's, we'll say, over in Indiana instead. And so that care is going to part of your transition of care with the managed care plan. It gives them time to work with that provider, get that provider under contract, and make sure that that child maintains their services. And now I'm going to turn it over to Sean to talk about the enrollment processes.
This is Sean Bracely. The next couple of slides are timelines about how enrollment will work for these children. The very first slide is regarding adoptive children. The enrollment process for adoptive children will be much like our regular enrollment process. In late October, families will receive a letter letting them know that their child will be mandatory for managed care enrollment. It will explain to them what managed care is, and also they can call the hotline to start comparing the plans and the plan provider networks. In mid-November, they will receive their official enrollment notice, letting them know that it is now time to enroll in a plan. Again, they can call the hotline to actually complete the enrollment. The Medicaid hotline also has all of the managed care plans provider networks, so the hotline knows which providers are contracted with which plans, which is usually one of the most important things in determining the managed care plan. If a parent does not make a choice in a managed care plan for their child, we will choose one for them. They will be assigned to a plan, and that plan will go into effect January 17 unless the parent calls that plan. Once they are enrolled in January, they will have the first 3 months after that enrollment to change the plan if they do not like the plan they are enrolled with. Other than those initial 3 months, they can change plans during open enrollment, which is November of each year. Okay, for the children that are in custody, went too far. As Patrick said earlier, we are enrolling children that are in custody in phases, and their enrollment process is much different because these children are in the custody of the county. So we have worked with 7 counties as part of a pilot to enroll about 400 children into managed care. Those children have been enrolled with an effective date of November 1st, and it has been communicated to the plans, and so the plans have begun outreaching with the counties to begin the needs assessments and care coordination for those children. ODM over the next month will be doing readiness reviews with the plans to make sure that the plans are ready to accept the additional 14,000 children in custody when we begin enrolling them November 1st. The purpose of the pilot is to discover any problems or areas that we need to improve prior to enrolling all of the children so that we can try and iron out as many problems as we can. And like I said, for the pilot children, their enrollment is effective November 1st. Then for the remaining children, we will be enrolling them in phases. So counties received instructions back in August about completing reports and selecting managed care plans for their children and indicating any children that needed to have enhanced care management. the counties were also able to choose November 1st or January 1st for an enrollment for their children. So on November 1st, we will be enrolling the children that had a November 1st date indicated by their local PCSA with an effective date of January 1st. Children that were identified with a January 1st date by their county will be enrolled with an effective date of February 1st. This will help the managed care plans to even out the load of the children coming onto their plans and doing that outreach with the counties, the needs assessment, and the care coordination. Children in custody, different from most other managed care populations, do have the ability to change their plans at any time. They are not locked into the first initial 3 months or open enrollment, but any change in plan that they request will be made the first of the following month. The managed care plans have provided single points of contact for all the PCSAs so that they know who to contact when they need to speak to someone at their plan. As Patrick said earlier, the PCSAs will begin to do all of their Medicaid eligibility and managed care selection in SACWIS, beginning hopefully by January, maybe earlier. And the managed care cards will be sent to the local agency unless otherwise designated by the Children's Services worker. And lastly, as I said, the plan selections from the PCSAs were due last Friday on September 30th. We have received those spreadsheets from many counties, but there are still some counties that we have not received the enrollments from. We need to receive those as soon as possible so that we can begin assessing those and complete the enrollments.
So, Sean, before you go on, I want to add one thing to the previous slide relative. And I think there was a question that popped up about kids not currently in SACWIS. So, first of all, it is true that once the system changes have gone into place, all the eligibility will be able to be determined in January or in SACWIS. We are going to ask counties for the kids not in SACWIS to try to have them entered into SACWIS by April 1st of 2017. Recognize that you could sort of ignore that request, but from a systems simplicity standpoint, the sooner that everyone is actually in SACWIS, the better the process will flow. So as we type out all the answers to some of the questions that are coming through, we'll sort of reinforce that, and we would just like to say, I think even though we recognize it'll be a fair amount of effort on the county's part, to the extent that all the kids that can be entered into SACWIS by April 1st, we think it'll be a lot better for the state.
Okay, so I will turn it over to Melina.
Yes.
All right.
Okay, well, good afternoon, everyone. My name is Christine Day. I'm from Molina Healthcare of Ohio, and I'm going to walk you through the next few slides just to give a high-level overview of the benefits. And many of these have been covered with the previous presenters, but I'll go into some in a little bit more depth. This first slide shows basic fee-for-service benefits that will remain in place. So inpatient services, outpatient services, including any federally qualified health centers, rural health centers, physical therapy, dental, all those kind of things will remain in place under the managed care. Next slide. However, we do offer value-added benefits. In addition to your county non-emergent transportation, we offer additional transportation benefits because we want to make sure that these kids get to their doctor's appointments, their dental appointments, redeterminations, WIC, whatever it takes. We want to make sure that we don't have any barriers to access. We also offer a statewide network of providers. In comparison to fee-for-service, all of our providers go through a pretty stringent credentialing process. We're looking at quality, and we do reserve the right, if there are any issues, we can certainly terminate those providers based on quality issues. We also, as Nicole had mentioned, we also all have a 24-hour nurse advice line that's manned by registered nurses. They are not there to direct care in any means, but rather just to offer guidance. If it's a mom who's worried in the middle of the night whether or not she should take her child to the ER, that nurse can help guide and help them make the right decision for the child. Care management is another very valuable added benefit, and one of the other plans is going to go through this in more depth. Enhanced dental and vision coverage. We offer biannually dental visits for adults and children, and every 12-month vision coverage. Self-service capabilities, there is a member portal where members can log in and print cards out of that area. Disease management and health education programs include asthma, diabetes, also maternity rewards for making sure that moms stay healthy during their prenatal visits, and also a member services line that members can call in to get any benefit questions answered. Next slide, please. There we go. And then for provider searches, there's a couple of different ways that you can look, and this is probably a pretty important piece when you're looking at selecting a plan. One area that you can go is to our online provider directory. Each plan does have a website that you can access. Another one is to call the member services, the managed care member services line. And the third one is to call the Medicaid hotline, and the number is there at the bottom of the screen. And lastly, okay, and lastly, I just wanted to touch on behavioral health providers. Any services that are covered under Ohio Department of Mental Health and Addiction Services will remain in place. Those will remain under fee-for-service until 2018 when behavioral health is carved in. So it's one card, give it to the provider, and we will go ahead and take care of the claims billing for you. And that's really all that I had for this piece. I'm now going to turn it over to CareSource to walk us through the care management.
Thank you. Hi, my name is Trish DeLong, and I'm from CareSource, and I want to talk to you today about our value-added benefit of care management. So we know children in custody often have some care management available to them, but this is a part of the medical portion to help support the needs of the children and families to navigate the healthcare system. So care management, we have goals of really improving health outcomes for our members and improving their quality of life. So how do we do that? We really focus on identifying and then eliminating any barriers to care, creating efficiencies between providers or departments within our space. We do collaborate with community providers to try to get appropriate utilization of services such as emergency rooms and inpatient stays. And we try to improve utilization by really doing that health and wellness touch, make sure that children especially are linked in with primary care, make sure that they're getting all the immunizations that they need, and preventative health services like dental and vision, and of course behavioral health also. So our care management team is really varied in their scope of practice, and we've done a great job, I think, in all the managed care plans, recognizing that we needed various licensures and team members to help interact with members effectively. So we have registered nurses on our teams, we have social workers, clinical counselors, family counselors, LPNs, and we work as a team to collaborate so that we can best meet our members and children's needs. Next one. So this is a very complicated slide, but the focus of it is how care management is really person-centered or member-centered. And we look at not just the member themselves, but the family, guardians, and all the services that need to be wrapped around that child for successful care. So, of course, that includes our PCSA workers and collaboration with them so that we're not duplicating services, but just another tool in the toolbox to assist our members to get the total quality of care that they deserve. So we focus on working with pharmacists in the community, making sure they're linked with that primary care practitioner. We really also focus on transitions of care because we know that's where some outcomes can get difficult, and so we really try to focus on providing safe and effective transitions from different levels of care. So what do care managers do? Well, kind of like care management in any space, our goal is to find and define barriers and then make sure that we fill those gaps in care. We do outreach in different ways. We can outreach telephonically based on triggers that we've identified that the family may need some support. We do have on-site people at different facilities also to help transition needs. So we work with our members in many ways to try to engage them into care management if they would benefit from that. We really focus on the member again. So we focus on what the family identifies as a primary need for this child. So if that's a guardian, a foster parent, an adoptive parent, or even a parent trying to gain custody, whatever that goal is for that family and that member, we focus on that first. Really trying to improve that health and well-being, getting them to doctor's appointments, and educating on plan benefits and any disease management concerns that they may have. So like I said, we really work in that space of the medical piece. So if you've ever had a complex medical situation in one of your families, this is kind of how I like to say how care management can really bridge that gap, because the medical can be very complicated and benefits management can be complicated, and the care manager is really there to help you make decisions and transition from different levels of care or different services that really help safe and effective quality care for our members. So we really do focus on quality. We monitor our providers and ensure that they do provide quality care and are meeting our expectations for outcome measures. We coordinate between specialists like behavioral health and primary care, and really explaining those benefits and the choices that a family has in making this medical decision.
Hi, this is Amy Baldridge from Paramount Advantage, and I'll be speaking to the next section, which is on service authorization and transitions of care. The first thing I'd like to do is just define what is utilization management. It's basically the management of the utilization of services, and essentially it's just authorizations. Most of you may be aware the way that authorizations work. I just want to go through a short little process. Typically what happens is the provider faxes or calls in the authorization request along with some clinical information. Once that's received by the managed care plan, usually a nurse or some type of other clinician reviews the clinical information, reviews the authorization request, and compares it against national criteria that are accepted across the country. Once that occurs, the nurse or clinician will make a decision on whether, based on the information that they have at on the clinical information, whether they can approve that authorization. If for some reason they feel they can't approve the authorization, it will be sent to a medical director or perhaps a pharmacist for review. Once they review the information, they will make a determination on whether they feel like they can approve it or whether they would proceed with the denial. One thing we want everybody here on this call is that the managed care plans, we want the right care at the right time because we believe that that's what will make for improved health outcomes. And everyone succeeds when we have improved health outcomes. Again, I mentioned the national guidelines and the criteria that we use that are accepted across the country. We, as Nicole mentioned earlier, we are held to turnaround times for authorization. Usually for pharmacy, it's a 24-hour turnaround time. And depending on what type of authorization that's sent in, that time period can vary. But we are held to the strict guidelines both by Ohio Medicaid as well as NCQA, the National Committee on Quality Assurance. We also will be honoring transition of care as required by Ohio Medicaid, and I'll actually talk about that here in just a second. Pharmacy authorizations, there are standard pharmacy guidelines which are put forth by Medicaid. The prior authorization or PA list is standardized across plans. The transition of care rules apply, and those are in Appendix C of our provider contract with Ohio Medicaid, and we are to follow those transition of care guidelines for pharmacy. For antidepressant, antipsychotic guidelines, again, the same rules apply. We will be honoring those transition of care and making sure that our members have the continuity of care that they need. The same thing applies for prior authorization process for pharmacy. There's a standard prior authorization form that most prescribers are aware of, and most authorizations have a 24-hour turnaround time. We do want to add that all drugs that are requested for prior auth are reviewed for safety guidelines. We want to make sure that our members are on drugs that are medically necessary for their condition. So we do have quality care and safety guidelines that we have our pharmacists review to make sure that our members are on the correct medications. And then just regarding the transition of care, we want to identify any member needs. So what we'll be doing is we'll be reviewing their prior authorization list for each member, reviewing the fee-for-service data that we receive, doing assessments on members, outreaching the member if appropriate, or members' authorized rep or personal rep. We'll be outreaching the PCSAs to determine what needs to be done from an authorization process for continuity of care. We want to assure minimal disruption. We want this to be a smooth process for everyone, including the PCSAs. We will be honoring the existing Medicaid authorized services. That's why it's so important that we have that prior authorization report. And for the 90-day, most of the authorizations are honored with a 90-day transition of care, and we will be honoring for that, at least that time period. We want to facilitate any needed services and prevent gaps in care or duplication of services, as well as barriers to care. We don't want to be a barrier for these children. We want them to receive the care that they need to get.
Hi, good afternoon. This is Christine Haydock. I'm with Buckeye Health Plan, and I'm going to spend a couple minutes talking about appeals and grievances. We'll start by just noting that there may be times when a denial is issued, and this is when a managed care plan is not able to approve a request for service. Examples of these listed are, it might be an elective inpatient admit. It could be an outpatient procedure, such as a request for an MRI. It could be a pharmacy need as well. The managed care plan does send in writing notification if we make a decision to deny a request to cover a service, if there is a plan to reduce, suspend, or stop services before you receive all the services that were approved, or deny payment for a service you received that's not covered by Medicaid. I will note under number 2, reduce, suspend, or stop services, with the transition of care that we will be implementing with the children in custody. Prior to that, there'll still be the 90-day coverage, and at that point in time, prior to us reducing, suspending, or stopping service, there will be an attempt at a home visit in order to meet with the caregiver as well as the provider of service. Thank you. Appeals. If a couple comments about appeals. If a member does not agree with a decision, they can request an appeal with the managed care plan. The member's provider can also initiate that appeal if they've discussed and it's been determined that the provider is the member's authorized representative. A lot of times you'll see the provider being the authorized representative. Many times they'll have really more complete and better information related to medical need than a member will. So if indeed that agreement is made, the provider is considered the member's authorized representative and can appeal. Appeals can be requested in the managed care plan. They can be in writing, by mail, person, or fax. A standard appeal is initiated within 90 calendar days from the day following the date of the adverse determination that it was actually mailed. An expedited appeal is available for urgent request. Those decisions are completed no later than 72 hours after that request. Many times expedited appeals are, we call it kind of like pre-service. You haven't actually started the care yet, and you feel that you need to have this looked at again prior to going further. All other appeals decisions are made within 15 calendar days. And the last section is grievances. If a member is unhappy with the managed care plan service or a managed care plan provider and notifies the plan, this is called a grievance. A good example of a grievance that we tend to use a lot as a managed care plan is many times there'll be a specialized service that a member requires. And it might be that there are only maybe 1 or 2 providers who actually do this level of service. Maybe they are not on plan with that managed care plan. That a member then can grieve that, and we will go ahead and do a very thorough look at that situation and then have a response for you. Grievances can be completed by calling the managed care plan. You can complete a form online, and I will note all the managed care plans do have these forms online, so it's quick and easy to get this information to us. They can also be faxed or mailed. The time frame for response and outcome on grievances, if it's a grievance related to not being able to get medical care, or you'll hear it at times called access to care, it's 2 working days. Most other grievances are 30 days except for billing issues, which can be up to 60 days. Assistance. The managed care plans have many staff designated solely to assisting members with questions or resolving problems. And we just want to take a minute to note, you've heard that we all have a member services area. The 1-800 number is always on the back of the managed care plan card. We all have 24-hour nurse advice lines. And again, these are great resources if you're not sure and it's after hours, a weekend, or a holiday, what to do. And I'd be remiss if I didn't note again care managers. Having a care manager work with you is definitely, to me, a real value added service. We're here to help you. We're here to walk you through any process you're not sure about. We're your advocate. If the managed care plan can't assist, there is still the ability to contact the Medicaid hotline at 1-800-324-8680.
Oh, yeah, that's right. All right, so this comes to the portion of the webinar where one of our folks could not be here, so I'm going to pinch hit. So this kind of goes without saying. really, and we've had a lot of meetings, a lot of discussions. This entire thing comes down to communication and the plans and the PCSAs working together. So really, you can sort of read some of these bullets on the screen. We think in a lot of ways, one of the huge questions that has come up has been around information sharing. We have developed a document, it's a fillable PDF in conjunction with the managed care plans and some of the counties that have worked with us on the work group to make sure that sort of all of our T's are crossed and our I's are dotted with respect to information sharing and HIPAA and who can share what with who. It will be one of the documents that we're going to send out following this webinar. So, you actually receive, and we will have the ability to email everybody on this webinar. We're going to send you the PowerPoint. We're going to send you some transition of care requirements that I think I saw come through as a question. We'll send you the information sharing protocol. We'll send you our frequently asked questions. Pretty much everything we've put together we'll distribute to this listserv so you can have a look. A lot of them have already been shared far and wide, but we'll send them out when we're done today. But I guess to close the formal parts of the presentation, this really does come down to communication. One of the things that we developed early on was providing the managed care plans with specific county contact information for every county in the state, and then specific contact information for all the managed care plans. So if we are successful in this initiative, I think it will. We've done a lot of sort of behind-the-scenes work to ensure that we have everything in order, but it's all going to come down to communication and folks working together. So keep that in mind, and to the extent that you as a county or a PCSA can really reach out and foster that relationship with the managed care plan on behalf of the children that you serve, I think the better off we'll all be. All right, so we have a couple more slides that Nicole is going to hit on relative to HIPAA. So Nicole, if you want to hit a couple of these slides, go ahead.
Good afternoon. One of the challenges that we came up against in going through these work groups and meeting with legal and the children's services agencies and the plan is about sharing information. It's not a concern for the adopted children because the adopted children, their parents are their parents. So they're the designated decision makers for them. But for the children in custody, it kind of got a little kinky, and basically the children's services workers and the managed care plans can exchange information back and forth, and most times the children's services agency or worker is going to be the one that's going to make the decision and authorize the care for the child. But there are going to be instances, because every county is different, every foster situation is different, every family is different, where the children's services worker is going to designate certain health decisions and certain health care communication to the foster family. And when they do that, there is a form that has been designed with the plans, Ohio Department of Medicaid, and ODJFS in the legal to make sure that, based on how the form's filled out, determines what information the plans can share and communicate back and forth with the additional authorized representatives that are designated. And then this slide just goes through the different types of appropriate authority that will be designated based on the different circumstances. And these have been communicated with the local county agencies, as well as providing them with fillable forms that they can submit to the plan. And we've talked several different times about how each plan has their own specific set of contact folks for, and so each plan has a slide at the end of the presentation that has all of their direct contact information for the folks that were designated as their primary contacts.
All right, so we're going to attempt to answer some of the questions that we've gotten so far. They're actually kind of difficult to read, so we're going to try to print them off, and we're going to try to go through some of them. We're not going to go through all of them, but again, we are going to take all the questions, and it's probably better if we just simply answer them in writing. But we're going to make an effort here, and I'm going to look around the room, and so people can help me out. We're going to try to answer some of these questions. So the first question we got was, one of the families I work with in foster care adoption asked if adoptive parents will be required to pay out of pocket for services that are fully Medicaid once the transition to Medicaid to managed care occurs, or will things still be covered at 100%? And the answer is they're not going to have to pay any more than they do today. The next question, if all Medicaid eligibility will be determined in SACWIS, what will happen to the kids that are currently open in Ohio benefits? Also, will non-4E eligible kids be enrolled in Medicaid through SACWIS as well? So the answer to that is yes, the non-4E people will be determined eligible in SACWIS. It is part of the system enhancements that we are working on, that I sort of alluded to. A webinar demonstration that we're going to do sometime in November maybe?
Late November.
Late November. And so the first part of your question is, what about the kids that are open in Ohio benefits? These are the people, correct me if I'm wrong here, Sean, but these are the people that we would ask the counties to then enter into SACWIS by April 1st of 2017.
Once the SACWIS system changes are complete.
There you go. Let's see, there was another question about, if you didn't see, I think we already answered it on the slide deck or in the question area, but the question of who are the 7 pilot counties. So let's see, we have Summit, we have Fairfield, Franklin, Richland, Clark, Lorain, Medina. Those are your counties. And so what we've done in the pilot is essentially identified a number of kids per county. All the plans are represented. As we move forward with this initiative, it's our hope that those 7 counties can be resources for some of the other counties on how things have worked and so forth. Let's see. There's a question about access to care requirements. Can we share those, and how do we define access? So I'll say it like this. When we can answer this question sort of in writing, and we can share generally what our access to care requirements are, which will help you. It may not get to specifics around, in such and such an area, Clark County, for example, each plan has to have X number of whatever specialty type, but we'll sort of provide some of that language. There's a question about out-of-state, and I think we've also answered this question online as well. But if they're in the custody of Ohio but placed out of state, your assumption is that they will enroll into Medicaid in that state, and that is the way it is done today. And the answer is yes, that's what will happen. The other question that has come up about out of state has been, what if somebody lives in Ohio but receives services in a border county, let's say in West Virginia? In that case, the child would enroll into managed care because their official residence is still Ohio. They just received some services out of state. Let's see. January. Oh, is there an option to send a second copy of the card to the caregiver's address? So I'm going to answer it like this, and if somebody else wants to add to it, be my guest. I believe the PCSA has the ability to have the cards either sent to the caregiver's address or to the agency. I believe it's all or nothing, as opposed to being able to specify for different cases where they go. I'll also say that we've had this conversation a number of times. At this point, there will not be a second card sent to a caregiver's address. However, some other documents that we will be sharing with all of you, we had each of the plans develop a one-pager or a two-pager providing instructions on how to log in to their web portal, and in most cases be able to print out something that will suffice as a Medicaid card. It will also give you instructions on how to request a second card. So while we don't, right now, there is no ability for the plans to send multiple cards, we will give you instructions on how to obtain a secondary card. Let's see. Does it make any difference what time of the month that the PCSA makes a selection to change plans? And will the new plan enrollment be effective the first of the next month? And the answer to that is yes.
Whenever they make their plan change, it will be effective the first of the next month.
There you go. Let's see. Are youth in county custody who are placed into residential treatment included in this plan to carve into a managed care plan? And the answer to that is yes, provided they're living in Ohio. Will there be a training on how to enter and select a managed care plan in SACWIS? And yeah, so that was the comment about the webinar demonstration that JFS is going to provide in probably late November. So again, look for a communication from JFS on that. From what I've seen, the changes are pretty straightforward, and for those of you that are familiar with SACWIS, it should not be that complicated, but you will be able to identify your plan selection in SACWIS. Let's see. I think many of the remaining questions we've hit on to some extent. Here's a question. What are the time frames for prior authorization other than for treatment other than prescriptions? So that's something we can also distribute to you all. I actually think we have, but we've got a sort of a comprehensive prior authorization document from all the managed care plans that I think will help tremendously. So we'll put that on the list that we'll share. Okay. Anything else come through on there in the last minute or two? Okay. So at this point, what I think we're going to do, I'm just trying to look at some of the remaining questions that have come up. I think at this point what we're going to do is we're going to take back the remaining questions that we did not answer. We will compile all the documents that we mentioned, send them out via email. I would also say that we've worked very closely with the PCSAO on a lot of these things. So if there are questions or concerns that come up over the next few months, you're always welcome to shoot those questions over to the PCSAO, and they'll. I'm certain they will bring those to our attention. They're pretty good at that. And we'll go from there. Again, sort of thank you very much for listening to us talk today. Hopefully it was at least somewhat informative, and I think that once you get some of the documents that we're going to send out, I think that will help. Again, I would say the pilot counties are rolling through this process. In fact, I know that one of the plans is visiting a pilot county today, working on some initial dialogue and plans for some of the children. So I really do think that the pilot counties will be a good resource moving forward. and really thank you for your participation and for the work that you're about to undergo to make this a successful initiative. So lastly, I guess I would say we did record this webinar, and I think we're posting it on our website, correct? So we're going to save it. We're going to post it on our website. If there was something that we talked about that you sort of missed or you weren't paying attention, you want to go back and listen to, you'll be able to do that. Thank you very much, and talk to you soon.